EMS in their area. So we'll get started with our objectives off the bat. I really want to make sure that everyone understands that EMS wants POLST in their area and why that is. We'll talk a little bit about how protocols affect our patients in the absence of POLST, what EMS agencies need to do to be able to participate in the paradigm, and what are the factors which might hinder EMS from participating in the POLST paradigm. And I designed this session really for anyone involved in the POLST paradigm, those with knowledge of EMS as well as non-EMS folks who might be looking for ways to engage their service providers. So we'll start with just a little bit of background information about how EMS is organized. And on this slide, we use Missouri as an example because it varies by state. The Department of Transportation really determines the standards for EMS via the National Highway Traffic Safety Administration, but those standards may be modified by each state. And so states are responsible for determining the scope of practice and licensure of the providers in their areas. In Missouri, it's within the Department of Health and Senior Services. We have the Bureau of EMS, who is advised by the State Advisory Council, as well as 6 regional councils and the regional EMS medical director. And then you see in a bubble a little bit off to itself, most states have a provider organization that represents or advocates for those providers. But a couple of key things to keep in mind is that the medical directors are board certified physicians who oversee the policies and protocols of an EMS system or organization. And so the EMS providers operate under standing protocols with the option to call medical control for additional orders if it's something that may be outside of the typical protocol. So medical control then is a little different term, and it's used for any physician that may approve orders on their behalf. So in my particular area, there are 12 hospitals, each with their own physician groups who can act as medical control for the providers. EMS can be delivered in a lot of different models, so this can also vary by area or by state. And we'll start by looking at the option of providing a private versus governmental model. And private could mean hospital-based, it could be profit, ambulance services, for-profit, as you see in the top left picture. For governmental approach, it could mean a third-party county-based service, as you see in the lower left picture, or it might be a municipal fire department-based service. There's also a distinction between non-emergent transfer services and 911-based service, so that's another distinction that may occur. We can differentiate service by provider level, so we can have basic life support, which would be staffed with EMTs like you see in the top right picture, or advanced life support, which would be staffed with paramedics that you see in both of the left pictures. Now, some models even use a combination thereof, 1 EMT, 1 paramedic to staff the ambulance. And now you see that we have a new sort of service model, sometimes referred to as community paramedic or mobile integrated healthcare, where EMS is responding to healthcare reform with initiatives that kind of move away from the emergency aspects to address some very specific community needs, such as managing high-frequency system users or helping hospital partners reduce their 30-day readmission rates, and giving patients alternative options for healthcare that don't require transport to a traditional hospital emergency room. For now, there's no common role definition or competencies or business models or metrics really across the country for how that type of service should be delivered. And in Johnson County, where I am, we don't have a community paramedic program, but we do have a fire department that has a mobile integrated healthcare unit, which is designed to eventually include a mid-level provider to address prevention and follow-up with patients who might be using 911 as a primary point of healthcare. So when you talk about EMS and POLST, you have to keep in mind that how POLST may be implemented in different states or different areas from an EMS perspective really begins to depend on all of the factors that we've discussed in the last couple of slides. Just so you have a understanding of kind of my frame of reference and my perspective, the lens through which I have experienced POLST and EMS, Johnson County is southwest of the Kansas City metropolitan region, and my service provides dual paramedic advanced life support response to about 37,000 911 calls per year to 20 cities over 473 square miles for about 560,000 citizens. We have several municipal and district fire departments that provide first response. Some of those are ALS first response. We have about 66 nursing homes in the county, 6 hospitals in the county, and 6 more in the greater metro area that are capable of providing medical direction for us, and then additional facilities we can transport to. So if you think back to 2 slides before, our service would be described as a governmental third service, emergent ALS ground transport. So that's sort of my frame of reference. So if we get right into our first objective and talking about why EMS wants POLST, I'm going to, I think, best illustrate that through a case study. And this is an actual call I ran. We were dispatched, fire and EMS, to a code 1 closest, which is our highest priority call, to a difficulty breathing. We arrive at a residence to find a patient's husband who says that his 62-year-old wife has a terminal cancer diagnosis and she's at home on hospice. And you might be asking yourselves, why then did he call 911? I know I kind of turned around and looked out the front door at my mobile intensive care unit, or ER on wheels as some refer to it, and certainly wondered the same thing. But we proceed to find the patient unresponsive with agonal respirations and a palpable carotid pulse. So the patient's husband informs me that she has a valid pre-hospital DNR form and that she would not want to be transported to the hospital. So I posed the question to all of you to consider, what would your EMS service do in this particular situation? And the answer probably is as varied as the audience that has joined us today. The patient's husband continues to confide in us that he is her second husband and that she has 3 adult children, and he's not comfortable making treatment or transport decisions without them being involved. So you can imagine, as a service provider in the home, in the face of this critically ill patient who you might describe as being in respiratory failure, sort of the conundrum we found ourselves in. So your EMS service may just initially think to their protocols, and what kind of guidance would they find in their protocols. And they may first refer to a respiratory distress protocol. That's what they were dispatched to. That's really the chief complaint we find with the patient, other than an altered mental status. But would treating her respiratory failure and transporting her to the nearest ER emergency or emergently honor her wishes? Based on what the husband has described, is that what would be in the best interest of the patient? So they might look a little further in their protocols. They may, like I have shown here, have an example of a protocol that addresses pre-arrest patients that present with a valid advance directive. Unfortunately, these kinds of protocols give little guidance in terms of what specifically should be done for that patient. It uses words like appropriate interventions and caveats, and be considerate about performing heroic measures, consult with the patient and the caregivers to understand previously expressed desires to limit care. So it tells us to take into account what the patient wants, but doesn't give us really any specific guidance. So the protocols sort of fail us in this scenario. So your crews then might think about their policies. Do we have any policies that would apply to this particular situation? For us, we have an out-of-hospital DNR policy, but does that apply? Not until the patient is in cardiac arrest, so that one doesn't apply. If she's refusing, or we interpret that she would refuse treatment and transport, can we go by the refusal policy? And unfortunately, the policy requires that a patient be alert and oriented before they can refuse treatment or transport. So we're kind of left in this situation with the tools that we would normally go to resolve a situation, leaving us still with a question as to what is the best course of action for this patient. To be honest, if we were to strictly go by protocol and policy, it would likely lead providers down the treatment of respiratory failure path with rapid transport to the nearest ER. If we look a little deeper into our profession, we might refer to the EMT oath. And the EMT oath was created in 1978, adopted by the National Association of EMTs, and was written by a physician, Dr. Charles Gillespie. And the oath is very reflective of the Hippocratic Oath, which assumes much more of a doctor-patient relationship than we are afforded in emergency settings that we respond to. And if you look closely at the EMT oath, it says, "Into whatever homes I enter, I will go into them for the benefit of only the sick and injured." And so it's sort of that medical ethics principle of beneficence there. But does that really clarify what would be best for this patient? Is it more beneficial to treat and transport her? Is it more beneficial not to treat and transport her? So we take it a step further. We say, well, what about our code of ethics for EMS? Does it provide additional guidance? And the code was written by the same physician, has been updated as recently as June of 2013. And if you look at the quote here on the slide, as an EMS practitioner, I solemnly pledge myself to the following code of professional ethics: to conserve life, alleviate suffering, promote health, do no harm, and encourage the quality and equal availability of emergency medical care. You'll quickly recognize several of those principles of medical ethics: the beneficence, like we've seen in the oath, the non-maleficence in terms of not doing any harm, and justice. What we don't see in either the oath or the code of ethics is any reference to patient autonomy and the patient's ability to make their own decisions. So these tools also fail to provide us some specific guidance in the case of our 62-year-old female cancer patient at home on hospice. Your crews might then ask, are there other advanced care planning tools we could refer to in this situation? Advanced directives or a living will? Is there a durable power of attorney health care? And that might be another option for looking for some guidance. But the trouble with advanced directives is that they're often not on scene with the patient. The DPOA healthcare may or may not be on scene. In this case, the patient had not appointed a DPOA of healthcare. And because these are legal documents, they're typically written in legalese, and I can say that with ultimate respect because I'm married to an attorney, but they may be very long and difficult to interpret in an emergency setting like we were faced with. Unlike physicians, we don't have the benefit of the history with the patient or a long-term relationship during which we learned about their values and preferences. So I think what you'll find in most agencies is if these kinds of documents or guidance are not available, when in doubt, EMS will default to full treatment and rapid transport to the nearest appropriate emergency department. EMS is known for erring on the side of preserving life, which sounds good, except that if you really look at what that means and you look at what's highlighted here in red, it means that really for this patient we are doing the exact opposite of what she had clearly communicated as her wishes to her husband. And so this tendency results in a phrase you may be familiar with: you call, we haul. And so you're beginning to have a sense of what it means for patients who may want something other than full treatment and transport like we are used to defaulting to. Our protocols default to full treatment. Our medical control often defaults to full treatment. So EMS defaults to transport, and then the only transition of care option really is to an emergency room physician. So knowing now how the current tools we have available would fail to help us solve this ethical dilemma, you begin to see what could happen to this 62-year-old female cancer patient. In the absence of POLST, her family may be unable to agree on her wishes. I am assuming you have all had some experience with that when the patient's husband told me she had 3 adult children he wanted to bring into the conversation, I started to tremble at the knees in the possibilities for where that could go. The patient would likely be treated for respiratory failure, transported to the nearest emergency department facility, and hold on to your seats, but can you imagine that in some cases they may even consider giving Narcan for a possible overdose to address her respiratory failure. She'd be placed on a ventilator and go to the ICU, and unfortunately her wishes would only be honored upon cardiac arrest. So you begin to quickly understand that EMS wants POLST really to enable them to do the right thing for the right reason. We're looking for the best possible outcome for the patient and need the infrastructure and the tools to help make that happen. Since we currently don't have a protocol or medical order allowing for anything other than full treatment prior to cardiac arrest, POLST gives guidance for patients who have other wishes, who may still have a pulse and be breathing even though they're actively dying. So if you're curious as to what did happen in that particular case, the patient was given supportive ventilation and oxygenation. Hospice was contacted and requested to come to the scene. Her adult children were contacted. They, as well as hospice, arrived fairly quickly. If you can believe it, all of her family agreed that she would not want to be treated aggressively or transported. So we contacted medical control, who actually granted orders for us to transfer care to hospice and leave the patient on the scene. So you may be asking yourself, well, isn't this the way it's supposed to happen? Sounds like, it all worked out great. What's the big deal? And I can only tell you that this situation is probably the most unusual alignment of stars to ever occur in my career. Consider if any one of the family members had disagreed, we would have been required by our policy to treat and transport. If hospice had been unable to respond in such a timely manner, if medical control had said, you know what, I'm not familiar with this patient, just bring her on in, we'll sort it out when we get here. All of those were opportunities or factors that may have caused us to be forced to treat and transport her, even though we knew that that would not be in alignment with her wishes. In fact, this call was so unusual in our system, the crews went back to the station and actually had a short debrief about what it was like to leave a critically ill dying patient at home. Because all of our training is centered around rescue and resuscitation, we really have no experience in palliative care. So how EMS can engage in POLST happens at multiple levels, the individual service level, at the local level, regional level, and state implementation are all important to making it successful. So we're going to talk about engagement at each one of these levels next. At the service level, one of the first things EMS needs to do is to review their current policies and protocols for potential conflicts. And I've copied and pasted here a subset of my very own cardiac arrest and resuscitation protocol from my agency. And I use it to point out, and I know the type is really small, so I'm not expecting you to read it, but to point out that we have a policy, and it's actually documented in our protocol, that resuscitation should be initiated if any family member or legal guardian requests emergency care. So what that means is that I can have a patient with a perfectly valid out-of-hospital DNR form signed by a physician, in date, to my knowledge, the best representation of what the patient would want. But if any family member comes into the room and says, no, I want you to resuscitate them, then that's what my protocol requires me to do. And so in terms of POLST, this is not, it doesn't conform with the intent, right? We want POLST to honor a patient's wishes regardless of what any family member may walk into the room and say. So the very first step is for an organization to identify some champions, perhaps an implementation team made up of field providers and educators and administrators, and certainly you need medical director support because you can't change protocols without it, to really look at what kind of protocol do we need to have in place to support POLST in the best possible way. So you'll find some agencies will select a cardiac arrest protocol which highlights non-resuscitation situations and refers to an appendix where a list of valid advanced care planning documents can be honored by EMS, where those might be found. There's different approaches. Based on my research, most agencies take a similar stance, while some give EMS clear direction not to initiate resuscitation of the valid out-of-hospital DNR as available. So imagine the situation that happens on the scene with family members. In either case, you have a patient with a valid form and family wants you to resuscitate, there's EMS caught in the middle. Or you have family members on scene that say the patient doesn't want to be resuscitated, but we don't have any documentation to go along with it. So in most cases, EMS there is caught in the middle. So when we look at the service level and reviewing the current protocols for potential conflicts, one of the things we might consider doing is developing a comfort measures protocol. There's a couple different ways this can be done. And the patients who select attempt resuscitation and full treatment on their POLST forms are obviously the easiest for EMS. That's what we're used to defaulting to. But patients who select limited additional interventions can be challenging. But in general, if intervention is required, then so is transport. So we can get through most of those situations. But those patients who select comfort measures only in any combination are really the most difficult for EMS to support because most of us don't currently have a comfort measures protocol. And so there are some agencies who have developed that type of protocol, and I see they've kind of taken one of three paths. One would be a very generic, non-specific protocol that just directs EMS to consult with medical control. So if you're ever in this situation, just call medical control and they'll help you decide what to do. The second option would be that they develop something that resembles general guidelines more so than a specific protocol. And the third option would be to create a palliative care-driven specific protocol for implementation, and that's kind of what our area is trying to do. So let's take a look at an example of each of those kinds of protocols. The first one here comes to us from Ohio, and you can see that this protocol doesn't give much guidance beyond what may already be noted in Section B of the POLST form. It doesn't specify how much oxygen or how it should be delivered. It doesn't specify the administration of medications that may not be carried by EMS or doses that may be given that would be outside the typical EMS protocol. So that falls into that first area of kind of a generic non-specific protocol. The second example comes to us from Utah. And in this case, we see a little bit closer in terms of specificity. It's expanded and differentiates patient complaints that may be addressed, and it's more specific than just provide pain medication. It gives a little bit more specifics in terms of what kind of medication, what other things should be considered, what a comfort treatment might look like. And the third example comes from King County, Washington. You can see kind of a change in the slide template, and that's because this was taken directly from their EMS training presentation. And in this, you have another example of kind of a general guideline protocol with a little bit more specificity in terms of how oxygen should be delivered and how much of it. So it's just another example of general guidelines. This one has sort of a catch-all at the end of it that says contact the patient's physician or online medical control if directed by local protocols or if questions or problems arise. So kind of a general guideline with a safety net that says when in doubt, go ahead and contact medical control. What we're trying to do here in this region is to create a comfort measures protocol for our initiative. And in our area, we refer to the POLST paradigm as TPOP. It is our Transportable Physician Orders for Patient Preferences. So this is a draft of a comfort measures protocol. It's a cooperative effort of our medical director, who's the division director for palliative medicine at the University of Kansas Medical Center, along with medical directors from several area EMS agencies, both in Missouri and in Kansas. And we'll talk a little bit more about this medical director work group when we get to talking about regional implementation. But the idea here is that the protocol is based on what a palliative care team would provide for the patient at the hospital, and EMS becomes an extension of that care. So this would give us specific guidelines for administration of medications and options for providing comfort for the patient beyond some of the general guidelines you've seen with the other examples. In addition to reviewing the protocols for potential conflicts, we also have to ask ourselves, do we have any policies that conflict with the intent of POLST? And some of the areas we might want to specifically look at is how we currently process pre-hospital DNR forms. Do we have guidelines that say we can only accept original DNR forms rather than photocopies or faxed copies like what would be accepted with POLST? Do we have policies that make it difficult to honor that DNR? So for example, we have a signed DNR reflecting a patient's wishes. If the family disagrees, what is the guidance for EMS? Have we built that into our policy? Have we given the providers a way to respond to that particular situation? Have we walked them through sort of if the family member is there who has power of attorney, that would be strong support, or if other family members disagree, or even if other family members disagree. Have we talked to them about verbal statements from family members who have power of attorney or close relatives, and how that could be given priority over someone not as close? So have we really thought about the situations we put our providers in and given them responses to those situations? So that's an example of a policy that might need to be reviewed or edited or addressed in order to allow for successful POLST implementation. At a local level, if we get beyond the individual EMS service, at a local level we really need to partner with our community agencies, first responders, facilities where patients are picked up, where they're delivered to, and some of the hospice and home health agencies, and and have a discussion about expectations with each of those. If you think about it, when we get back to the first responders, you have potential for police agencies that carry AEDs and respond to cardiac arrest. So if we don't bring them into the loop with POLST implementation and talk about what it means if they respond to a cardiac arrest and find a patient with a POLST form that specifies do not attempt resuscitation, how that changes how they would respond to that call. With long-term care facilities, hopefully they're engaging in POLST implementation on their own, but the transition of care and determining when 911 will be accessed is important and something that has to be discussed. Hospital EDs, again, where we're taking our patients, we hope are engaging on their own, but that transition of care, the request for POLST-related orders, all of those things need to be coordinated. And so education regarding hospital destination is important as well. Do patients understand that your hospital destination may depend more on their condition than their preferences, things like that. And then this graphic kind of depicting the wheel of hospice care sort of highlights the fact that we have work to do in building relations between EMS and hospice. We're not noted there as a part of that hospice wheel. So what can we do at the local level to build relations and provide education to all of our community partners to make the implementation successful? At a regional level, we have to think about what it means to transport a patient out of jurisdiction or cross state line. Here in the Kansas City area, obviously we're very close both to Kansas and Missouri, so we have to understand if we have a patient with a POLST form or a TPOP form in Kansas, what happens if I transport them to a Missouri hospital. The consistency of care among the multiple agencies with multiple medical directors is critical, and that's why we chose to use the Mid-America Regional Council Emergency Rescue Committee as an avenue to ensure that when we talked about implementation in the Kansas City area and developing a comfort measures protocol, we have a real regional perspective because that agency or that team represents all fire and EMS agencies in a 9-county bi-state region. So it's a way to make sure we have a coordinated effort on a bigger scale than just each individual agency kind of doing their own thing. When you talk about state implementation, if we look back to the org chart for EMS, we have state medical advisory committees that need to be involved in the implementation, and you may have a state board or bureau of EMS that needs to be on board as well. Ultimately, they can issue support for or regulations regarding POLST implementation. And in here, I'll use Kansas as an example. The Kansas Board of EMS passed a resolution in support of TPOP. And the last two sections are really important, where it talks about that the board supports TPOP as a method to better understand and meet patient preferences for better end-of-life decisions, and that the board supports the incorporation of TPOP into an ambulance services EMS medical policies and protocols in Kansas. So for Kansas, this resolution really was the green light statewide for EMS agencies to begin making the changes to protocols and policies that we've been talking about. So if some of you are struggling to get EMS engaged or involved or able to make some of the changes we've talked about or develop the infrastructure, there's always a good reason why. So I wanted to present some of those as well. The first one we've already discussed a little bit in terms of the lack of palliative care, comfort care protocols. You got to remember that as EMS providers, as I mentioned, all of our training, everything that we're taught to do is to rescue and resuscitate. So changing that focus for a patient who does not want to be resuscitated or who may want a different level of intervention is kind of a whole mindset change for EMS providers. There was a recent study in Pennsylvania that showed as much as 15% of EMS providers would still provide CPR when faced with a patient who had selected do not attempt resuscitation comfort measures only. And unfortunately, the conclusion drawn from that study was that POLST may cause confusion for EMS providers. But what's interesting is a little bit of research revealed that the state of Pennsylvania actually has an out-of-hospital do not resuscitate protocol that specifically states that advanced directives, living wills, POLST, and other DNR forms that are not valid Pennsylvania Department of Health out-of-hospital DNR orders may not be followed by EMS providers unless validated by a medical command physician. When presented with these documents, including a POLST, CPR/resuscitation should be initiated and medical command should be contacted as soon as possible. So when you peel back the layers, you discover that the interpretation or the actions taken by the providers are very reflective of a protocol that's been in place for them. And the protocol really sets them up to be unable to withhold resuscitation or provide comfort measures without medical control validating the order. And so the study isn't a reflection on POLST, but it really kind of drives home the point that without appropriate protocols to support POLST, EMS may be unable to honor the patient's carefully documented treatment goals. And we'll talk on the next slide about why Pennsylvania has such a valid reason for having that type of protocol and why it's an additional barrier. So that's barrier number one. The second one would be financial concerns. In most systems, EMS is paid only when they transport a patient. So if we see a patient and they refuse transport, even if we treated them, we don't charge them. So the potential for loss associated with a comfort care or comfort measures only patient who requires treatment but not transport is very real for some of those systems. And then operationally, if you think about how an EMS system is designed to work, it is that you respond to a call, you treat a patient, you transport, and you return to service to answer the next call. So again, this comfort measures patient who does not wish to be transported but requires some treatment ties up resources from responding to other emergent transport necessary calls or patients. In the example I gave you of the call I ran, we were on scene with that 62-year-old female cancer patient for about 45 minutes. And in some systems, that amount of scene time would not be acceptable. So you've got to look at the operational or system demands that may be hindering EMS's ability to implement POLST as intended. The next item would be legislative concerns. And there are a lot of cases where state law regarding EMS protocol and practice impacts that state's ability to implement POLST. And at issue really is how specific is the law. When EMS began to honor out-of-hospital DNR forms, many states passed legislation allowing them to do so, and some even granted immunity to EMS providers when doing so. But the language of much of that legislation is specific to that one form, the out-of-hospital DNR form. So the legislation may not necessarily extend the same ability to honor a physician order or the same immunity be granted to EMS for anything other than that original out-of-hospital DNR form. And in those cases, gosh, I think we can all appreciate the legislative process can be long and arduous. Some POLST programs find it very difficult to get those statutes updated. So if you think about Pennsylvania, and I described a protocol that says even if a patient has a valid POLST form, we have to resuscitate them until medical control can verify and approve that. The reason for that protocol is legislative in nature. There's a state law in Pennsylvania that says they can't honor anything but that original out-of-hospital DNR form. And so again, you peel back the layers. Well, why is this a problem for EMS? Well, they have a protocol that says XYZ. Well, why do they have that protocol? Okay, there's legislation behind that protocol that requires them to do that. And until we can get the legislation changed, we have a hard time implementing as it was designed. In terms of training and continuing education, these situations, if you think about them, tend to present us with a high risk but low frequency type of call that requires a lot of judgment on the part of the providers that make it very difficult to train on. And the what-ifs abound. We try to have a class with EMS providers about patients that may have a POLST form. We can spend all day saying, well, what if this, what if that, what if these are the set of circumstances? So you find that it's a difficult training and continuing education issues for EMS. And given that we're currently required to do more training on duty and pay less overtime for training, that becomes another sort of issue with implementing something so different. So the training really has to include an effort to change the expectations of EMS providers that when someone dials 911, it may not necessarily be a request for resuscitative effort. Different paradigm for us. And then if you think about documentation and technology requirements, we still have some agencies with handwritten patient care reports. Others use electronic medical records. So figuring out how to document what was on the POLST form is critical both for quality assurance and any research that might result from implementation. For our agency, we use an electronic medical record. We have the opportunity to select TPOP as a particular form in a tab, and then we're able to scan the form in upon arrival at the hospital and attach it to the EMR. Again, if you think about the unusual patient who may refuse transport, it provides some logistical questions about how do we capture copies of that form and attach it to the medical record. So documentation can also be a challenge for agencies as they look toward implementation. But there is hope. I hate to end with all the barriers, so if you think about some of the possible solutions for our future and how we can successfully implement from an EMS perspective, one of those is the evolution of the community paramedic programs that I mentioned before. It helps us maybe to identify other reimbursement options, maybe provide some operational or system demand relief for those cases where you have a patient who is a comfort measures only and doesn't wish to be transported. Can we call in the community paramedics to stay on scene until hospice is able to arrive and we transition care to them, allowing the ambulance to return back to service and answer other 911 calls. So we have some hope that that might help as well. Another solution would be the standard of care approach. This can help us avoid some of the legislative issues. Rather than trying to pass a law about POLST implementation, can we do it as a standard of care? Can we do it because it's a physician order and we don't need a law to back up a physician order? From an education perspective, can we utilize distance education to ensure we get appropriate initial and continuing education? So does that, along with the use of technology, allow us to overcome some of the training and education barriers? And technology may also answer some of our documentation questions as well. The key here is that the solution to each of the barriers that we've been discussing are so very agency specific, maybe area specific, maybe state specific. So each state will be influenced to address them differently. I pose these as just a few high-level ideas to help get people on the right track. So I wanted to save some time for questions, but in summary, I hope everyone is comfortable with the concept that EMS wants POLST and why we need it, but that we need protocols to be able to honor it appropriately and implement it the way it was designed, that we need initial and continuing education to recognize and apply POLST in those emergency situations like I described, and that if you're not an EMS agency, to recognize that EMS really needs you as their partner, because there's certainly always a handoff from EMS to someone, and we need those partnerships built and strong to help support those implementation and those decisions that may be made on the scene. So I thank you for your time. I think Hannah will facilitate the question and answer session, and we'll go from there.
Yes. Yeah, most definitely. Thank you so much, Angela, for your presentation. We did have two questions come in. The first question is, are any states requiring that a patient sign an AMA or a declined transport document when they have a POLST document that shows that they only want comfort level interventions?
So I'm unaware of any states that are requiring that. And I'd be really uncomfortable with that, because there are certainly patients who have chosen comfort measures only who may still require and want transport. If I can't keep a patient comfortable in their current setting for whatever reason, then that would warrant transport to the hospital where they could potentially be kept comfortable. So I hope that clarifies.
Great. A second question that came in was if you could just clarify if emergency medical services in Pennsylvania, if they require the original form or if a copy is valid.
So you're asking me about Pennsylvania. I can't answer whether or not they accept photocopies and faxed copies. I know that's how POLST is designed to be implemented. It has caused us here in Missouri and Kansas to change what we require for an out-of-hospital DNR form, because we did used to require the original, not a copy, photocopy or fax copy, and now we've changed that to be in the same vein as POLST, where we are allowed to accept those photocopies and fax copies. So again, that could be something that is agency specific. It's getting over some of those old policies that were in existence prior to the implementation of POLST.
Okay, great. Let's see, another question that just came in. And someone was wondering if they can refer their local emergency medical services department to you to answer questions about implementing POLST.
Absolutely. I will caveat that with saying I may not have specific answers for them if I'm not familiar with their state legislation, but I can at least help them identify some of the steps for where to start and where to get that information and how to navigate some of those questions.
Well, I think that's all the questions that have come in so far. Oh, we just had another question. If you could clarify the types of protocols to honor POLST.
I'm going to make sure I understand the question. Clarify the types of protocols to honor POLST. So, Doctor, do you mean what kinds of protocols would honor POLST, or what kind of protocols would need to be in place?
Both.
What types would honor POLST? So I'll take a stab at that. You would, if you think about the POLST form and how it's laid out, typically the first section is whether or not a patient would want to be resuscitated in the situation of cardiac arrest. So it would affect your cardiac arrest protocol. Do you have in your cardiac arrest protocol an area where it indicates that patient preferences communicated via a POLST form will be honored at the time of cardiac arrest? Then do you have a protocol that would address that comfort measures type of patient? That's typically one that has to kind of be created from scratch. And then it can affect some of your other protocols. If you think about airway management or respiratory distress, some of the common conditions that you would encounter with these kinds of patients, do any of those protocols need to either mention or reference the fact that we would honor treatment as documented via a POLST form? Please let me know if that doesn't answer your question. Like we have clarification too for Pennsylvania, they do accept copies of the POLST form. Thank you for that.
It looks like that's all the questions that have come through so far. And again, this webinar is being recorded, so we'll get the webinar posted and sent out to everyone.
Oh, looks like we have a new question.
Oh.
A great question, very common question about how orders coming through on the POLST form may be written by physicians that don't have privileges at a specific facility. And what I would say is for years, EMS has worked under the same type of environment with these out-of-hospital DNR forms. So we encounter a patient who's in cardiac arrest, has an out-of-hospital DNR form signed by a physician that may or may not have privileges as their medical control, or at a facility that they would maybe be transporting that patient to. Now, that would be only if they didn't honor the form. EMS agencies, as far as I know, have always been able to accept those orders or those out-of-hospital DNR forms signed by another physician as being valid. So for EMS, it shouldn't be a concern with that kind of form having a physician order that comes from a non-medical control physician, but that is a conscious decision and policy made on the part of the EMS agency that is implementing. So for our region, it wasn't an issue as to which physician signed the form. If it was a valid form and contained the signatures that were required, then we agreed we would honor that form. It's also then a conscious decision on the part of the receiving facilities to determine if I, as an emergency room physician, receive a patient with a POLST form signed by a physician who doesn't have privileges at my facility, what do I do with that form then? And I think the recommendation is that you take that information along with your assessment and all the other information you have gathered about that patient and use it to determine what orders you will turn around and write as that physician. Any other questions? I spoke a little fast today. I apologize for that, so we still have time if anyone else has questions. So I think Hannah will make my contact information available to all of the participants. Is it on the website already, Hannah?
I think it might be, but yeah, I will definitely make your email address available to everyone. And people are also welcome to send me an email if they have questions or additional comments. That would be Hannah, Hanna, @polst.org. There will also be a little survey that will go out at the end of the webinar, just as another opportunity to provide any follow-up comments.
Definitely look forward to your feedback. If there were areas you hoped to hear about that we didn't cover, please let us know so we can make revisions for the future.
The question that just came in, it says, would it create more confusion if additional protocols are used when a POLST form gives definite guidelines?
Not sure, when we say additional protocols, do we mean the creation of a comfort care protocol? Because I think what we were striving for is to take the guidance that you would find on a POLST form and give our crews some specific actions that could be taken. Now, a physician could choose to write very specific additional orders on the POLST form outside of what's generally written in each of those sections, and in that case, that's all that would be necessary. But for physicians that don't do that and we just have Section C, for example, selected with comfort measures and not really any specific guidelines, there are some agencies that were looking for more information. So you may review a POLST form and not need additional protocols to be able to support it, but I'm not sure that that's true for very many agencies, because it's again a paradigm shift in that one type of a patient who selects the comfort measures only. For the patient who selects attempt resuscitation and full treatment, that goes along with everything EMS is used to doing, so they would just use they wouldn't need any additional protocols for that.
All right, well, it seems quiet at the moment. We can definitely hang on for a couple more minutes. Any other questions come up? Great, Angela. I think that's probably about it for now. So yeah, again, thank you for
everyone.
your time. And yeah,
Pleasure.
so all right, thank you everyone for listening in. We do appreciate it. And have a good afternoon.